Welcome to CareTalk, your happy haven for insightful debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix.
Well, John, in the midst of all the COVID-19 talk, one thing made the news, which is Atul Gawande has departed from Haven. What the heck?
To be fair to him, reforming healthcare, putting all of our hopes on one brilliant writer and surgeon, may have been misplaced. Perhaps he's going to be a better critic outside the system than trying to build something. What about you? You're up there in his neighborhood in Cambridge. What do you think, David?
I sure am. Well, John, just to remind people, Haven was formed a couple of years ago by Amazon, JP Morgan, and Berkshire Hathaway, really to try to change the whole healthcare system. Atul Gawande, real visionary, hired for that. I mean, I remember right from the start, there was some skepticism or even cynicism about it. Can they really do something that others can't?
We were pretty darn skeptical, David.
No, we were, John. And I think it's not just with him, but, I remember, a decade or more ago when, Pfizer and Microsoft and IBM got together for electronic medical records, which was the issue of the day in Amacor. At least they had a product. I think there was, one of the things that I heard people say was, well, rather than try to change everything, maybe they should just put all this effort into lobbying for single payer healthcare that might have more of an impact.
What I had hoped Atul would be able to do is hammer on a few critical things like he did with surgical checklist, where he not only determined that surgeons and teams following checklists could actually lead to a considerable drop in all-cause mortality from all surgeries if they just followed the list, but then they went two steps more and actually determined that if you required a list, the doctors didn't follow it, which is what happened in Scotland. And if in some other areas they asked voluntarily surgeons to change behavior, it didn't work, even though, again, just following the checklist like a pilot does before taking off in an airplane saves lives. And in Canada, where they collaborated with doctors and worked with them to make them understand how they could improve things. And he really not just articulated the change that needed to happen, but how to make it happen within the system. If he picked off a couple of those things, David, I think he might have been successful.
John, he also faced certainly some structural challenges in terms of the different company cultures, Amazon going off and doing its own thing, for its own competitive reasons against, strong players like Walmart. It's also a nonprofit, so it's hard to attract and retain the top talent. I think it's telling that, he felt in the midst of this coronavirus crisis that was the time to leave. He wanted to make an impact there. In a sense, Haven's inability to respond to the coronavirus, I think, is the final straw. I mean, if there's ever a time to disrupt healthcare, it would be now, with more of a digital-first solution, with digital as more than just video conferencing, greater use of the home. But the fact that they lacked the agility or the power to do anything, I think was really why he headed for the exits.
It's really a loss. I think that your skepticism was warranted. But gosh, if there's a time to bring in systems and business thinking to healthcare and thinking of us as trying to solve our national or local problems together, now's the time probably to go back to academia.
John, with your idea about focusing on a specific thing to knock off, let's talk about a specific thing, not COVID related so much, but I think it has a role here, which is the area of readmissions, which is one we've talked about a lot. And I guess the question is, how is COVID-19 affecting readmissions? And what are people doing about that specifically at this time?
Well, I think what CareCentrix and we've focused on a lot is empowering patients and their families with information about what the next best place to get care is and provide more options and support for care and aging at home. And that's what we do. So we're constantly fighting the centrifugal pull of hospitals and nursing homes to grab those admissions, regardless of whether they're clinically relevant, because that's their business model. And I think that what COVID-19 has done is dramatize the danger of being around a bunch of other sick people. And so it has made the alternatives of care at home and in the community, where you don't end up getting stuck in a hospital or nursing home for any longer than you need to, a lot less attractive. I still think that we are a long ways away from providing patients and families the support they need, and for providers, how patients are faring from their players like CareCentrix and others, so that we can shift more care to the home. But that's where it's going, David. The long tide of care out of large institutions and into home and the community that started with things like ambulatory surgery centers, around which there was a lot of pushback. I think COVID-19, in the same way it's accelerated the acceptance of telemedicine, will accelerate the acceptance of more care to the home. I mean, what do you think?
Well, I think so, John, as well. I mean, I wanted to get my head around this kind of question about readmissions. It's a hard question to answer because there's fewer people going to the hospital, so there aren't as many readmits. The people who are hospitalized have more severe illness, so that causes causes an issue as well. And then there's also, there's either disruption of people needing to go back to the hospital or redoubling of efforts to keep people from going back. But I think that your main point is quite correct, John, which is that it's gotten people used to the idea that you don't really want to go to the hospital. You want to be at home. There's no reason we can't provide people with the support they need to stay at home. And I do think that will be a long-standing impact of the coronavirus once we're past it.
Don't hide behind complexity like you sometimes do. Yes, healthcare reform is hard, but let's get to first principles here. We've got to keep people in the healthiest place possible. And given the hugely expensive cost of U.S. healthcare versus anywhere else, we got to make sure they're in a more affordable setting like the home.
John, one thing I've been thinking about a lot is Medicare, which is, of course, a topic we've been covering forever. And there's this concept of Medicare buy-in. And I think that, one of the things that may happen is that as you've got older workers, so-called older, 55 plus, let's say, may see some early retirements of people scared to go back into the workforce. They're not Medicare eligible. They may or may not have access to their employer plans. And I think this concept of kind of Medicare buy-in or just lowering the age for Medicare may become more popular. Do you share that view?
I think it makes a ton of sense. I mean, we still have a real crisis of coverage or lack of coverage, which leads to a tax on all of us because eventually people get sick and need to get care. We should have more access to care. As you know, we were big supporters of the exchanges and Obamacare. I think Medicare buy-in makes a ton of sense, particularly for those older employees that are increasingly closer to our age, David, who don't have a lot of options. And I think the simplest way would be to allow them to buy into Medicare Advantage. And have that be the exchange, if you will. A lot of these Medicaid plans are actually for those who can't get care, not that bad. I mean, I think that we should look at the private sector, public-private alternatives there, at a minimum, Medicare Advantage.
I agree. I think any expansion of Medicare should be with Medicare Advantage. And I also think that, Medicaid for all is a better approach than Medicare for all. And it may be something where a Medicaid buy-in as a kind of a backstop for anybody might be a simpler way to go. But I think, Medicare's...
Explain to folks what that means, because you're using technical language.
John, the Medicaid is traditionally meant to be kind of a safety net for the poor. It provides, though, quite broad coverage. It doesn't pay physicians and hospitals that well. It's less expensive than any kind of private plan. So the idea would be, rather than having an exchange or individual commercial insurance like you would buy out in the market, that should be able to just join your state's Medicaid plan. But if you had too high of an income, you'd have to pay something for it as opposed to it being free.
I think that would be a great plan and an alternative that folks aren't talking about. It's almost too practical.
Well, good, John. So listen, we've covered a heck of a lot of important things here, and I don't want to bore the listeners too much. So I say, let's wrap it up right here. This is David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. Thanks for listening.
Hey there, listeners. Want more Care Talk? There's more to be had in our other episodes, so be sure to look for those and subscribe to Care Talk on your favorite service.